Greetings, everyone. I hope you're enjoying the Aging Conference in sunny Barcelona. My name is Fleur Newton, and I am the lead clinical psychologist in Reading Older People's Mental Health Team, part of Berkshire's NHS Trust in England. I will be sharing with you a piece of practice-based research looking at the effects of cognitive stimulation therapy groups for dementia on participants' attitudes to aging. This study was completed as part of a larger doctoral thesis for Oxford University. Starting with some key concepts and objectives, cognitive stimulation therapy, or CST, is a brief psychosocial intervention for older people with mild to moderate dementia, comprising 14 multi-activity, multi-sensory themed group sessions which aim to stimulate various areas of cognition and enhance social functioning. Examples of themes would include things like word and number games, sound effects, current affairs, and categorizing objects. It was developed by Amy Spector in 2003 following a large multi-center randomized control trial. It is a person-centered group that draws on reminiscence approaches and is very much strengths-based. So it's focusing on the skills retained by the person with dementia and aims to engage their personal opinions, views, and experiences rather than talking about facts. CST now has a well-established evidence base as a non-pharmacological approach for improving cognition and quality of life in patients with dementia. And it's currently one of the only psychosocial treatments recommended for cognitive symptoms in people with dementia by our NICE guidelines, the National Institute for Health and Clinical Excellence, which is our gold standard for best practice in the UK. CST is now delivered across the UK, both in NHS settings and also in voluntary organisations, and as well as globally, with work going on in at least 34 countries. And there is now an international CST centre based at the University College London. So despite all this, however, there is a lack of practice-based research, with most studies consisting of tightly controlled and well-funded RCTs. So this study aimed to explore the effectiveness of CST groups in busy NHS clinical settings, where resources are limited and variables are very difficult to control. So the question was, does it work in real life? This study also aimed to explore the effect of CST on ageism attitudes. And as I'm sure you're all aware, ageism can be defined as a process of systematic stereotyping and discrimination against people because they are old. So self-ageism develops when these negative perceptions about our own age groups are internalized and become part of the self-identity, like stereotypical views of older people as needy or dependent. This is important as studies show that these negative ageist beliefs have been linked to poor health outcomes and poor well-being amongst older people with a dementia diagnosis. They've also been associated with a decreased quality of life rating and less therapeutic engagement. This study, therefore, is a response to calls to investigate these negative aging self-stereotypes further, even as possible mechanisms of change in CST, which is seen as a potentially destigmatizing intervention due to its person-centered focus. This may assist us in developing future interventions for older people that are clinically effective and destigmatizing. Moving on to design and method, a quantitative pre-test post-test design was used to evaluate changes in participant outcomes at the start and end of the 14-week CST program. Unfortunately, we were not permitted by ethics to create a control from our waiting list. As CST was considered best practice, it was not deemed ethical to withhold an intervention that may benefit the person with dementia. In future research, we plan to create a control from participants who turn down CST but who access other similar activity groups. In this study, participants comprised a community sample of older people over 65 years of age with a diagnosis of mild to moderate dementia across our 6 NHS sites in Berkshire. A total of 100 participants were included in the study at baseline, and 82 participants completed. All our measures had proven validity and reliability and comprised the MMSC, the Mini Mental Status Examination, as our cognitive screen, the QAL-AD, the Quality of Life Alzheimer's Disease Scale, which explores 13 domains of well-being, including things like health, mood, and living situation, as well as the AAQ, the Attitudes to Aging questionnaire developed by Laidlaw in 2007. This is a 24-item cross-cultural Attitudes to Aging questionnaire comprising 3 subscales. So attitudes to aging around psychological growth, psychosocial loss, and physical change. And the higher the score, the stronger the endorsement of that particular attitude towards aging. All data was analysed using SPSS. So this table shows the demographic characteristics of our sample, which ended up being highly representative of the broader older adult population in the UK, which gave us some confidence. Our 18% attrition rate was also comparable to other studies. So our sample was made up of 35% male and 65% female, the majority of whom lived in community and who took anti-dementia drugs. And the mean age of the group was 82 years. This pie chart simply shows the dementia diagnosis by subtype, which, as you can see, consists predominantly of Alzheimer's dementia at 56%, and then vascular dementia at 32%, with the remaining 12% being the rarer and more unspecified dementias. This was also consistent with the national statistics for older adults in the UK produced by our Department of Health. So here is our results table, which shows the changes from baseline to follow-up on clinical outcome measures. So on the far left column are the measures, including cognition, quality of life, and the Attitudes to Aging questionnaire, both the total score and the 3 scale scores. Then we have our pre- and post-test mean scores, any mean changes, and the level of significance. And as you can see by the stars on the right-hand side, we have 3 areas of significant change in quality of life and across the Attitudes to Aging questionnaire. So let's have a look at our most significant findings in terms of the impact of CST on our routine outcomes. What we found in terms of CST and cognition was that there was no statistically significant difference in cognition from baseline to follow-up, with MMSE dropping by 0.27. And while this was inconsistent with findings in the RCTs, no change on MMSE is potentially a positive outcome for us in clinical practice, where an average 3-point decline is expected every year for people with dementia attending a memory clinic. So this provided evidence of a possible holding pattern. In terms of CST and quality of life, there was a significant difference in quality of life scores from baseline to follow-up, suggesting CST has a positive effect on participants' perceptions of their quality of life, and this is consistent with previous research. In terms of our new measure, CST and Attitudes to Aging, a significant statistical difference was found pre- and post-test for total AAQ scores and also for psychosocial loss, suggesting that CST has a positive influence on attitudes to aging overall, with higher total AAQ scores representing a reduction in negative aging self-stereotypes, suggesting that the person is aging more successfully. So other interesting findings included differences between the completers and those that dropped out. Overall, there were no differences on all demographics, suggesting similar effects across age and gender. There were also no differences across clinical measures, except for one subscale of the AAQ looking at psychosocial loss. So those people that dropped out scored lower at the outset on psychosocial loss, suggesting they may have come into the study with less perceived loss, and this may have influenced how they felt about staying in the intervention. However, we need to be cautious in our interpretations due to the relatively small sample size and lack of a control. The other important finding was the significant positive relationship or correlation between participants' attitudes to aging and their quality of life, suggesting that the one may influence or improve the other. And this is clinically relevant to us, as I will explain on the next slide, looking at the clinical implications. So what are the clinical implications of this study? Well, first and foremost, and most importantly, this practice-based study provides further evidence that CST benefits the routine outcomes of cognition and quality of life in everyday clinical settings for older people with dementia. It is reassuring that CST still works in busy NHS clinical settings with limited resources, varying staff complements, group sizes and environments. And it highlights that there is a psychosocial option available beyond memory clinic diagnosis and medication that is worth the investment of staff time and effort, that is also valuable for the person with dementia, especially with vascular dementia where there are limited medication treatment options. The study suggests that CST is equally applicable across age and gender, and this is important as it can be made more widely available to a growing number of our older people with dementia in community. It is also the first empirical study to show that CST has a positive effect on attitudes to aging in older people with dementia. And this is important given the high health costs of negative aging self-stereotypes in older people. And it also reinforces the malleable or changeable nature of these attitudes to aging and suggests they can potentially be ameliorated or shifted using a psychosocial intervention in everyday clinical settings. CST may also have additional benefits as a positive aging intervention, and AAQ may have utility as an extra measure to provide policymakers a way to evaluate psychosocial interventions for old age. And this positive correlation between quality of life and ageism attitudes is clinically relevant for us, as quality of life is increasingly becoming a measure in dementia care. So improving one may improve the other, especially as there's a move towards more qualitative measures looking at well-being rather than cognitive measures, which have limited value in a deteriorating condition. So ending with current developments and future research, while the COVID pandemic limited our follow-up research efforts in terms of face-to-face CST, it did give us on our patients something else of value that I'd like to share with you, and that's the opportunity to innovate and to adapt our service delivery of CST to an online version called VCST or virtual CST, something we could never have imagined possibly doing if it wasn't made a necessity by the lockdown and the resulting social isolation of our patient group, whose dementia had made them increasingly vulnerable to deterioration. So our trust conducted a pilot across all the memory clinics of virtual CST. We developed working groups to adapt the content, and we offered it to people with dementia on Microsoft Teams with the help of a carer. And I have to say, a lot of us were quite skeptical at first and had to confront our own negative bias about older patients with dementia using technology. And due to the complexity, we could only gather qualitative measures, but we did receive a lot of positive feedback that I'd like to share with you. So in terms of some of the advantages, patients and their carers felt there were still benefits to cognition and well-being. And we received a lot of lovely anecdotal comments about people feeling happier and more engaged and connected. We also received feedback that this innovative adapted delivery was made more accessible to those in lockdown, reducing their social isolation. There was always also feedback about improved levels of confidence for older people in using technology and feelings of resulting empowerment. So challenging those very negative self-stereotypes that we're concerned about. In terms of some of the disadvantages, the first one was the tech poverty, which was seen as a barrier to accessing services. So unfortunately, this was not equitable, as those without computers or the internet or carers to help could really not participate. Also, some patients with sensory difficulties like hearing or visually impaired found it more difficult to engage on an online format using a screen. So clearly it's not for everyone, and we need more thoughts and more research and more development in this area. So consequently, this year, the International CST Centre, based out of UCL, have been looking into virtual CST across all the various NHS trusts. And we've all participated in a survey, and they have started a University College London-based randomised controlled trial to explore the benefits of virtual CST on routine outcomes. So that's very exciting. And in the meantime, they've also produced some really helpful interim guidelines for those services wishing to run CST virtually. So in terms of our future practice-based research, it may be timely for us to wait for these findings and to try to replicate them in clinical practice. So maybe you will see us again and we can feedback at a future conference about the benefits of online virtual CST. Thank you.